want to go to the next slide, please. These show the goals of what is being looked for from patient-centered medical homes. And we have check marks in the boxes for the areas that actually have been shown in studies to be happening. So, and on our next slide, we'll summarize the studies. But the Patient-Centered Primary Care Collaborative is very active in collecting data on the impact of patient-centered medical homes. And they have found actually, and much of that data comes from health plans. They have found it to reduce burnout, as shown in physician satisfaction. They've shown that patient-centered medical homes are associated with lower total health costs, fewer emergency room visits, fewer hospital stays, and fewer hospital readmits. That data is being collected even as we speak. I would really encourage you to go on the PCPCC website. They continually update the data on the impact of the patient-centered medical home. And then on the right-hand side, it is expected to produce positive outcomes, and that has been shown through a number of studies, particularly of diabetes. Patient satisfaction, physician leadership is a key component of the patient-centered medical home, and one that that we work with physicians to develop. Care management, really advanced and comprehensive care management, is another really important factor that grows out of patient-centered medical homes really knowing their populations and really organizing around the need of their populations so that those patients with greater needs, they apply greater resources to those patients and make sure that they have what they need, that the patient-centered medical home is checking with them, is referring them for health education where necessary, and for specialist consultation. So the patient-centered focus, that's growing. We don't yet have data on patient self-management, but that's another important goal and one that we work hard with primary care practices on. And then productivity, we also have some very kind of anecdotal early data, but it is definitely a lot of practices that convert to patient-centered medical homes find that they are able, even in the absence of financial incentives, to generate more revenue, see more patients, and provide more comprehensive care. So the next slide summarizes the specific studies from the most recent complete patient-centered primary care collaborative update of the impact studies. The one from Michigan made a lot of headlines. They found that they avoided $155 million in total costs over 3 years. Vermont has really been a leader among the states in the patient-centered medical home, as has North Carolina. And Vermont Medicaid, as you can see, has seen major decreases in inpatient utilization and emergency department use. And then Health Partners in Minnesota, always a leader in the country, has shown huge decreases in appointment wait time. They've moved toward really advanced access. And as you can see, a huge increase in optimal diabetes care, which is the percent of patients that actually meet 5 measures of diabetes care. New Jersey, Horizon Blue Cross, you may have seen their headlines also. They have found really great, not only quality performance, but cost savings with the patient-centered medical homes that they work with, and they provide significant support for them. Then Queen City Physicians, another leader from Cincinnati, has posted reductions of 34% in ER visits and 22% in uncontrolled blood pressure. So these are just sort of standouts. There are a number of other reports from other states, from the Veterans Administration and the Air Force, where the development of patient-centered medical home model has been very active. So I will now turn it back over to Peggy and Guy for questions.
Great, thank you, Linda. So to wrap up, as Linda walked through the example of PCMH, it really does show this three-step process for defining value. There are three themes that we mentioned regarding the value in healthcare, and we want to just emphasize how Discern works with its clients to help drive value. In terms of defining performance, we've had a lot of experience working with clients on what measures define success, how can we collect and score these measures. In building provider payment models, we've looked at how do we pay providers and align incentives with performance. And then offering technical support for transformation. Linda talked about the PCMH model, and we have some work that we've been doing, particularly in Georgia right now. We've been working with the Georgia Academy of Family Practice, helping family practitioners through what we're calling PCMH University. And all the practices are now at the final stages. We've been helping them review their evidence prior to NCQA submission, and they're in the final process of submitting to become a PCMH through NCQA and have committed to do it by the end of this year. We're going to open up the phone lines now for questions, and also read off any questions that might have come through over the web. Have we gotten any questions over the web? Okay. So we're going to open up the phone lines for questions, and I think there's something we need to do technically to make that work. Okay, the phone lines are open now.
Hi, Peggy. This is Debbie Kilsey from INCAP. I have a question for you.
Okay, great.
Can you talk about examples of how health plans have helped with the PCMH transformation support?
Sure. So this is Guy. I mean, probably the most fundamental thing that a health plan can do to help with the PCMH, to move the PCMH model forward, is to think about their payment model for primary care and whether there's an opportunity to align that model with, with a patient-centered care approach. Right, so to the extent that those incentives exist in a market, we certainly see where that drives adoption of the model. If you were to look around the country, for example, at the concentrations of NCQA-recognized PCMH practices, you would find there's a strong correlation with where incentives are offered for primary care practices to operate as a medical home. Beyond that, there are examples where health plans actually provide more direct technical support, for example, providing care coordination support to patient-centered care practices to better help them manage their patients as they navigate across multiple providers in the health system. Linda, do you want to share any examples from your experience, either in Georgia or elsewhere?
No, those are good examples. I would say that direct payments, partial capitation and raising fee schedules certainly gets providers' attention, and as Guy said, where that is done and to the extent that it's done, you see more recognized PCMH practices.
Right. And then another example is where health plans share data back with the PCMH practices.
Right.
And that's something that's still emerging in terms of how the best mechanisms to make that happen. But of course, if you're a PCMH practice, one of your key challenges is to identify those patients that that are most in need of the kinds of interventions that you might offer. So knowing which of your patients, for example, have a recent ER visit, knowing which ones have have been high utilizers, that helps a primary care practice figure out, okay, where can I invest what ultimately are scarce resources in managing this patient population to the best possible results. Do we have any other questions from folks who are on the phone? Okay, go at once.
Kelsey from ACAP again. I have another question if you
Sure.
don't mind. It has to do with what I would call bundle payments, but I think you call episode payment.
Mm-hmm.
And I know there's been a lot of work in Medicare, and a lot of it has to do with joint replacements, knees and hips and that type of thing. But there hasn't been as much work on bundle payments in the Medicaid environment, and I would think that maternity care, prenatal care through and including NICU care would be an area that could benefit from episode payments. What are your thoughts on that?
I agree. I mean, most of the work has been done in the Medicare world and frequently on fairly brief episodes of care that have relatively low variation. Right? So the longer the episode of care is, and the more variation inherent in that episode of care, the more challenging an episode payment model would be. So you mentioned NICU care as being part of the bundle, and my instinct is that you might actually have to exclude the NICU part of the care only because it drives so much variation in cost that it would almost be impossible to have an episode payment that was large enough to handle all the potential NICU costs, or you could build a stop-loss wraparound in the episode bundle to handle those kinds of cases. But certainly even within more routine variation in maternity care, I think there would be a lot of interesting opportunity to build care bundles, for example, that would help to address issues like C-section rates. I mentioned that earlier. Early elective deliveries. So in the slide I showed earlier that was talking about how you have different kinds of care or different kinds of issues you want to address through payment reform. For example, whether or not the care is necessary in the first place or whether there's variation within the episode of care. Bundled payment works very well for clinical areas like maternity care where there's little question about the need for the care for the episode, but there can be a lot of variation within the episode because then that bundled payment would tend to drive that variation down. So I agree with you that that's actually an excellent opportunity to apply bundled payment concepts. But you might have to do it in a way that doesn't expose the provider completely to the extreme outlier costs that might occur, for example, with a NICU stay, only because at the end of the day, the provider doesn't have the resources to bear the kind of risk associated with those events. But again, you can address that either by excluding those events from the bundle or by putting a reinsurance component into the bundle so that they're not fully at risk for those costs. Any other questions from our participants on the phone? Well, if not, thank you very much for joining us today. On behalf of Peggy, Linda, and myself, we thank you for your attention. We'd welcome your interest if you think that Discern can help you with any of these phases of driving value in the healthcare system. You can see on the screen Peggy's contact information. It's easy to find our website as well, and all of our contact information is there. And that will conclude the webinar.
And the webinar it has been recorded and will be posted on our website as well. So if you have colleagues that you want to listen to it, they can listen to it as well.
Thanks, everybody. Have a great day.